We're thrilled to have with us Dr. Kimani Paul-Emile to discuss her work on dealing with racist patients. Dr. Paul-Emile is an associate professor of law, associate director and head of domestic programs and initiatives at Fordham Law School Center on Race, Law and Justice, and faculty co-director of the Fordham Law School Stein Center for Law and Ethics. She received her JD from Georgetown University Law and a PhD in American Studies from NYU. She specializes in the areas of law and biomedical ethics, anti-discrimination law, and health law. Dr. Paul-Emile received a public health law research grant from the Robert Wood Johnson Foundation and a Faculty Scholar Award in Bioethics from the Greenwall Foundation to carry out original research in policy and clinical dilemmas at the intersection of ethics and the life sciences. Her scholarship has been published widely, including the Virginia Law Review, UCLA Law Review, George Washington Law Review, and the New England Journal of Medicine. Please join me in welcoming Dr. Paul-Emile.
Thank you for that introduction, Rachel, and thank you, good morning, and thank you for inviting me here today to talk about an important issue that's been getting a lot of attention lately, and that's what to do when the patient is racist, and what are the legal, clinical, and ethical implications for patients, providers, and healthcare institutions. So let's start with a case study with a scenario. A 57-year-old man arrives in the emergency department late one night with shortness of breath and fever. A nurse does an initial workup and thinks his condition could be serious, so she gets Dr. Jones, the physician on call, to do an evaluation. When Dr. Jones enters the room, the patient says, "Oh my God, I'm so glad you're here. Since I've arrived, my television hasn't been working. Can you just fix my TV?" Dr. Jones explains that she's a physician and that she's here to do an evaluation, and the patient gets agitated and announces, "I don't want to be treated by any black doctors. Get this woman out of my room. I want a real doctor." Now, you can fill in the blank here with regard to the rejected physician. It could be a Latino physician, it could be a Muslim physician, it could be an Asian physician. Any of these categories apply. And scenarios such as this occur at hospitals throughout the country. And in fact, they're more common than one would think. In fact, I call it one of medicine's open secrets, because you'd be hard-pressed to find a physician, particularly a physician of color, who hasn't had this experience or who doesn't know someone who has. And this issue has also gotten a lot of media attention lately because of recent events in Charlottesville, Virginia, and elsewhere. And what's so difficult about these patient-provider encounters is that they raise many thorny legal, ethical, and clinical questions for all the parties involved. So for example, as you know, although physicians have an obligation to treat all patients, even those patients they find distasteful, these encounters can be painful and degrading indignities for the rejected physician. And these scenarios are particularly difficult when the patient is competent, but isn't stable enough to be sent elsewhere. So before we get into this, let's take a moment to identify the three primary groups whose interests are implicated when these encounters occur. What are the three primary groups who are affected in these scenarios? Patients, exactly, we have patients. Who else? Healthcare institutions, so hospitals. We have patients and healthcare institutions. And what's the last group? Staff, exactly. Physicians, like clinicians, right? Nurses. So here we go. So let's take a second to identify the interests that are implicated for each individual, for each group. Let's begin with patients. What are patients' rights or interests that, what are the patient's rights? Stabilizing treatment? That's right. So patients have a right, have a right to receive stabilizing treatment. This is in keeping with EMTALA, the Emergency Medical Treatment and Active Labor Act. It requires hospitals to screen and stabilize if necessary in patients in an emergency situation, or to arrange for a transfer with patient consent to a facility able to provide appropriate care. Okay, so what's another right patients have? With these, the right to refuse treatment, exactly. So let's call that informed consent. Patients have a right to refuse medical treatment, which includes the right to refuse wanted treatment from an unwanted provider. This right to refuse is a well-respected legal and ethical principle that's based in informed consent, and legal rules that protect patients from battery, which is unwanted touching. Okay. Many hospitals also have patient Bill of Rights documents that include explicit language about a patient's right to refuse treatment, and sometimes refuse treatment from unwanted providers. I was recently up at Brigham and Women's Hospital, and here's their patient's Bill of Rights document. You'll notice at the bottom that it says, you have the right to refuse to be observed, examined, or treated by students or any other staff without jeopardizing your access to care. Now, as I mentioned, although many hospitals have Bill of Rights documents that include this language, not all of them do. So I looked at yours, and yours is among those that doesn't include the language about refusing for specific providers. Okay. Now, let's turn to physicians. Physicians and other healthcare providers have rights and interests that are implicated in these situations. What might some of these interests be? What are some physician rights that are implicated when patients reject physicians based on race or ethnicity? Just generally, broadly.
Safety.
Safety. Physical safety, so if the patient were to get violent, okay. Well, think about what relationship does the physician have to the institution? It's early. Employment, someone said employment, exactly. So although physicians have a duty to treat patients, they also have employment rights that have to be respected. They have a right to a workplace free from certain types of discrimination, including discrimination on the basis of gender, race, religion, ethnicity. These are considered legally protected characteristics. Okay. And finally, healthcare institutions. What might their interests and obligations include?
Is the discrimination that you brought up is if it's applied from the institution or from the patient? Because I think there are two different
From
parties.
the institution.
Okay.
From the
So,
institution.
But you cannot, you're not obligated, or you're not given the right of against discrimination from the patient
No.
based on your employment. No?
It's now I'm gonna walk you through some of how the law plays out before we get into sort of the meat of these relationships. But just broadly, the real interest of the foundational interest a physician has is an interest in a workplace free from certain types of discrimination. So we have the healthcare institution, the hospital. What are their obligations? To treat people, exactly. Again, we have EMTALA, it's the federal anti-dumping statute. It's a law that protects patients from being dumped by hospitals without first being screened or stabilized. And again, institutions also have to protect the employment rights of their employees. So for example, if a healthcare institution continually forces its clinicians to refrain from treating patients who have rejected them based on race or ethnicity, then the healthcare institution could be liable for creating a hostile work environment. Okay? So, these are the rights and responsibilities. Now, at this point, you're probably thinking to yourself, okay, this is all very straightforward, I get it. But it gets murkier the deeper you go. So, for example, with respect to patients, should the race or ethnicity of the patient matter with regard to how we deal with these cases? So should we distinguish among different types of patients making these kinds of demands and requests? And on the healthcare provider side, should different types of medical professionals have different rights and obligations? So should and does the law distinguish between nurses and physicians or others when these cases arise? And with regard to the healthcare institution, are they damned if they do, damned if they don't? If they accommodate the patient's wishes for a physician of a different race or ethnicity than the one assigned, are they opening themselves up to legal liability? But if they don't accommodate the patient's demands, will they be violating laws against battery by forcing the patient to be treated by an unwanted physician without consent? And on the other hand, if they don't treat and stabilize the patient if necessary, will they be liable for violating EMTALA? So it's complicated. And again, what do? There haven't been many clear guidelines for how to effectively balance all of these concerns. So my co-authors and I provide guidelines in an article we published last year in the New England Journal of Medicine entitled Dealing with Racist Patients. Our goal was to inform providers of the legal, clinical, and ethical issues that should be considered when these cases arise. And prior to this article, I wrote a lengthier law review piece in the New England and the UCLA Law Review, in which I examined the legal ramifications of accommodating patients' racial preferences in the hospital setting. And I have to say, when I first heard about these kinds of physician-patient encounters, I was shocked. My first instinct was this type of behavior shouldn't happen, and if it does happen, it most certainly shouldn't be accommodated. So I decided to research the issue. And as you know, I'm a law professor, and I research and write on issues that arise at the intersection of biomedical ethics, race, and the law. So I initially focused my research on identifying the laws that could be brought to bear on these types of encounters. And this led me to some seminal anti-discrimination laws, specifically 3 provisions of the 1964 Civil Rights Act. Okay, it's a federal law that bars discrimination on the basis of gender, race, ethnicity, and religion. So let's briefly go through each of the provisions that I initially thought would apply. First, there's Title II. It's the public accommodations provision, and it prohibits businesses from giving in to their customers' racial preferences. So if you went to a restaurant and you announced that you only wanted to be treated by white waiters or Latino waiters, then if the proprietor gave in to accommodated your request, she will have violated Title VII of the Civil Rights Act. So I thought this should work, but as it turns out, Title VII doesn't cover hospitals. It covers other public accommodations like bars, restaurants, theaters, etc., but not hospitals. So I moved on to the next provision I thought might apply, Title VI. It covers any entity that receives federal funds, which of course includes hospitals. Title VI prohibits hospitals from discriminating against patients in a way that denies them the opportunity to partake in the hospital's benefits and services. But as it turns out, although Title VI covers hospitals and applies to race and ethnicity discrimination, it's never been read to cover these types of physician-patient encounters. And here's why. First, there's the question of who would have standing to sue. Patients who want a doctor of a race or ethnicity other than the one assigned aren't going to challenge the hospital's decision to give them what they want, right? So who's the other party who might sue in these situations? The physician, exactly. The physician might challenge the hospital's reassignment decision. But guess what? Physicians can't sue under Title VII because it doesn't cover employment discrimination. So I turned to the last provision that I assumed would apply, Title VII. Among other things, it says it covers employment discrimination, and among other things, it says that employers can't cater to the discriminatory preferences of their clientele. And the paradigmatic case is the airline that singles out its female flight attendants and forces them to wear skimpy dresses and hot pants and tight shirts and says, we're not discriminating, this is a business decision, our clients love this is not discrimination. Well, courts have found very clearly that this violates Title VII, and I thought that, catering to the discriminatory preferences of one's clientele in the employment context sounds a lot like what's happening in hospitals. So I assumed I'd find some case law here, but as it turns out, there wasn't any. There haven't been any reported cases of physicians challenging the accommodation of patients' racial preferences under Title VII. And this is so even though we know these physician-patient encounters often arise. But there have been several cases brought by another group of healthcare professionals who've been rejected on the basis of race. Do you have a sense of who this other group of healthcare professionals might be? Nurses. Exactly, nurses and nursing assistants. Now, why might nurses and nursing assistants be suing while physicians aren't?
Union protection, lack of geographic non-competes, lots of national alternate employment availability, the list goes on.
Who just spoke? Raise your hand. All right, so there are a number of reasons, and chief among them is that often nurses are, part of the reason is that nurses tend to be employed by the hospitals where they work, while physicians tend to be independent contractors. So hospitals or some other healthcare institution that complies with the patient's demand to reassign a nurse is violating the nurse's employment rights. But again, unlike nurses, physicians tend to be independent contractors, and in order to maintain their independent contractor status, healthcare institutions can't have too much say or control over the manner and means by which they do their jobs. So physicians aren't being forced to comply in the same way we see happening with nurses. Instead, they tend to decide amongst themselves, based on each individual circumstance, whether they want to accommodate. And also, physicians tend to have more decision-making autonomy in general, irrespective of whether they're independent contractors. You know, we can list out many more factors, but these tend to be the dominant factors. So in broad strokes, that's the legal landscape for healthcare providers and healthcare institutions. But it doesn't answer the threshold normative question of whether we should accommodate these cases, or these patients. So now let's turn to patients. The case I opened up with is what I imagine most people envision when they think of a patient rejecting a physician based on race or ethnicity. But these cases can often look quite different. So we're going to walk through a couple more case studies. Okay. So here's one. We have our older Korean man. He goes to the hospital with symptoms suggestive of heart failure. He's provided treatment that offers a very good chance of success. He'd likely make a full recovery. And all seems to be going really well until one day he announces he only wants to be treated by doctors in suits. The staff is puzzled by his request, and it's ultimately denied. The patient becomes increasingly withdrawn and ultimately refuses treatment entirely. The hospital performs a competency test. He's found to be competent. So they respect his wishes as they must, and all treatment is stopped. Now, this would have been the end of it had someone not noticed in his file he had filled out a form requesting full resuscitation should he go into cardiopulmonary arrest. When confronted with a seeming contradiction, and after some prodding, the patient asked whether they had noticed that all of his treating physicians had been either Japanese or of Japanese descent. The hospital was in Hawaii, which has a large Japanese American population. The patient was Korean and elderly, and he remembered Imperial Japan. And he didn't think he could trust these physicians. He didn't think they'd have his best interests in mind. And the reason why he wanted to be treated by physicians in suits was that he noticed that a higher percentage of the non-Japanese physicians wore suits because they also taught in the medical school. Okay. So his request was sort of a more palatable way of getting what he wanted. So that's case study 2. We have, well, so we may go back. Can someone help me go back in my slides? There we go, thank you. Thank you, Rachel. Okay, so case study 3. We have an older African-American woman. She presents with symptoms suggestive of renal failure. She's fairly uncommunicative with her assigned physicians. She's giving very reluctant yes or no answers to their questions as they try to take her history. And at some point during this process, she sees an African-American physician treating another patient, and she points to him and says, "I want to talk to him." Okay? Why might this patient be discriminated? Yes?
History of physicians taking advantage of African-American patients.
Sure, perhaps she's had a prior negative experience with a non-African-American physician.
Or a history that has happened in research studies.
Can you say it again a little louder?
Historically, there have been research studies that were unethical.
Exactly. Or just a general distrust of the healthcare system. Perhaps she's had a prior positive experience with an African-American physician and decided, this is her preference. Perhaps it's simple prejudice. At this point, we don't know. Okay. Our 4th case study. The patient is Latina. She arrives in the ER after 2 weeks of rhinorrhea, sinus pain, and other symptoms suggestive of viral sinusitis. As she's getting her history taken, she declares that she doesn't want the assigned Latino physician. She wants an American doctor, which turns out to mean an Anglo-American doctor. When asked why she's making this request, she responds, she came to the United States because she believes things are better here. Better facilities, better treatments, better doctors. And she associates American doctors with white doctors. Okay. Now, let me ask you a question. How is the patient's request in scenario 3, how is it different from the others? Did anybody catch it?
Specific person. She's requesting a specific person rather than like a class of people.
Okay. She's not so much rejecting a physician as she is she's requesting concordance, right? She's requesting a kind of concordance here, race concordance. Now we see this with women who want a female OBGYN, or with Muslim patients who might want a religiously or culturally concordant physician. So in this way, that case study is a little bit different, but it's still discrimination. Now let me take you back to case study 2 for a moment, which is our older Korean gentleman. Physicians may see a similar version of this among veterans who don't want to be treated by a physician who reminds them of a former enemy combatant. Perhaps it's bias, but maybe it's PTSD. Now we can argue that discrimination is bad, and it often is, but the idea of discrimination gets a lot more complicated in the clinical medical context, particularly in emergency situations or situations where you can't simply tell the patient to take the doctor they've been given or to leave. Sometimes the patient's behavior very clearly seems to be based in bigotry or animus, but other times it looks a little different. Now, what might these patients, particularly patients in case studies 2 and 3, what might they be looking for? What seems to be underlying their request for a different physician?
A sense of safety, a sense of comfort.
Exactly, we'll call that trust, right? If you've ever been to an emergency, if you've ever been to the hospital or taken a child to the hospital, I'm sure you all have, you know that trust is the basis of the physician-patient relationship. You have to trust your physician in order to be fully open about your symptoms and intimate details about your life and lifestyle, to be willing to subject yourself to invasive physical examinations, to adhere to medications and therapeutic interventions. And trust is particularly important for patients who are underserved or who aren't from a privileged social class. So in this slide, you can see that they're not as trusting and don't feel as confident in the healthcare system. You can see across the bottom, I trust my physician, I trust my health plan, I trust hospitals. The trust is highest for whites and lower for non-Hispanic blacks, adjusted and unadjusted. And we see the same thing with attitudes. If you read across the slides here, it says, I'm afraid of hospitals. Hospitals often want to know more about your personal affairs than they really need to know. Hospitals have sometimes done harmful experiments on patients without their knowledge, as you've noted. And again, the trust is highest for is highest for whites and decreases for non-Hispanic blacks. And this feeling of mistrust that we see among members of racial minority groups isn't just random paranoia. In fact, some members of underrepresented minority groups have very good reason not to trust the healthcare system. Overwhelming evidence shows that racial and ethnic minorities still tend to receive poorer quality health care as compared to whites, even when factors such as health insurance status is controlled. And some of this is due to structural factors. But research also shows that, sadly, there's still a lot of racial bias in medical practice. And minority patients still disproportionately receive substandard health care due to physician prejudice. So for example, one well-known study published in the New England Journal of Medicine, in which a group of physicians were shown a series of randomly assigned videos, each depicting an actor portraying a patient describing symptoms suggestive of cardiovascular disease. All the patients were dressed identically, had identical health insurance, described their symptoms in identical terms, and presented identical diagnostic tests. Race and sex were their only distinguishing characteristics. The study found that diagnosis and treatment recommendations varied according to race and sex, and that black women were least likely to be referred for diagnostic tests and treatment. Now, in the years since this seminal study was conducted, many more studies have examined racial bias in the provision of healthcare. And what they found is that the overwhelming majority of physicians are egalitarian and hold non-racist views. And few providers exhibit overt or explicit racial bias. However, many providers do harbor implicit pro-white biases. Does anybody know what implicit biases are? What are implicit biases?
Subconscious bias towards one group.
Exactly. Implicit biases are thoughts or feelings that exist outside of our conscious awareness that are very difficult to acknowledge and to control. And studies show that implicit bias against racial and ethnic groups, particularly Black patients, negatively affects the quality of clinical relationships, clinical decision-making, and healthcare outcomes. In fact, a recent IOM study and several other recent studies show that physician bias contributes to the widespread and well-documented health disparities that we see among racial groups in the US. So for example, racial minorities are less likely to undergo needed bypass surgeries or to receive kidney dialysis or transplants, and are more likely to undergo less desirable procedures such as lower limb amputations for diabetes. And ER physicians are less prescribe fewer analgesics for Black and Latino patients, despite similar estimates of pain. Data, however, shows that for some patients, particularly patients of color, physician-patient race concordance may counter the effects of implicit bias, discrimination, and stereotyping by patients. And this is so even after adjusting for age, gender, education, marital status, length of the physician-patient relationship, health status, and socioeconomic status. Race-concordant relationships tend to promote more participatory decision-making, greater patient trust, more persuasive, more productive communication, and greater patient satisfaction. And all of this goes to the heart of the physician-patient relationship. Now, this doesn't mean that we need to default to race-concordant physician-patient relationships. Rather, all this is to say that although our first instinct when we hear about patients rejecting physicians based on race or ethnicity, our first instinct may be just to deny these types of requests. But in order to provide appropriate care to all patients, it may be necessary to distinguish between garden variety racism and patients seeking a physician who they feel will understand their experience, who will show them respect, and whom they can trust. So the question then becomes, how can this be accomplished? And then, how should providers respond to both types of requests? My co-authors and I suggest that the solution may be found in the consideration of 5 ethical guidelines. There we go. These factors include consideration of the patient's medical condition, an assessment of the patient's decision-making capacity, the reason for the request, the physician's options for responding to the request, and the effect on the physician. We believe that these guidelines can inform physicians' decision-making capacity as they engage the patient through negotiation, persuasion, and if necessary, accommodation. So let's go through each of these factors and apply them to our case studies. In every case, the patient's medical condition should first be assessed, and this should drive clinical decision-making. In an emergency situation, an unstable patient should be treated and stabilized, and the patient's decision-making capacity should be assessed because requests that seem to be based on bigotry or animus could be due to delirium, psychosis, or dementia. And the patient's preferences could change if reversible conditions are treated. So in our first case study, for example, the physician may want to make sure that the patient isn't cognitively impaired because, as you know, cognitively impaired patients aren't ethically or legally responsible for their actions. If the patient is competent, he may be open to persuasion. A member of the medical staff or an on-call administrator could explain that all the physicians on staff are equally qualified and that the patient's health could be jeopardized by any delay caused in trying to find another provider. And while doing this, the physician should try to establish mutually acceptable expectations for the provision of care. Another option is to try and enlist the patient's family to help persuade the patient to accept needed care. Okay. Now the next step in this process is to try to determine the reason for the request because the justification may be clinically and ethically significant. So for example, it may be ethically appropriate to accommodate reassignment requests that seem to be seeking language or cultural concordance. So as we've discussed, it's not always so clear-cut, though. So with case study 1, fix my television. Maybe it's bigotry. Case study 2, perhaps it's PTSD. Case study 3, Is a patient seeking race concordance? Case study 4. Is this a misunderstanding about the physician's qualifications? So to get at this, you want to ask open-ended questions. And you can ask the patient to tell you more so that you can better understand their concerns, all the while acknowledging that these types of conversations they're difficult. They're more difficult than most. And you can also stress that if the patient is open with you, and completely honest about what's really driving this request, regardless of how socially unacceptable it might seem, you're better able to provide appropriate care, or the best possible care. So you're trying to identify and name what may be underlying the discriminatory remark, which is a big part of establishing trust. Now, this works if you think that the remark might be based on fears or anxieties, but it might be less successful if you're dealing with open bigotry or racism. So this brings us to the next factor, which is the physician's options for dealing with the request. If only one physician is available, or if the physicians don't want to reallocate patients, you can try to negotiate with the patient to allow her to provide care, to allow the physician to provide care until another physician comes on duty. So for patients 3 and 4, this type of negotiation might be effective. If the patient still refuses, then you have to pursue other options. If the patient is an outpatient, they can be informed of their right to seek treatment elsewhere if they object to a physician on racial or ethnic grounds. For inpatients, if they're stable and their request appears to be based on racism or bigotry, then an on-call administrator could inform the patient of her right to receive care elsewhere and her responsibility not to engage in hateful speech. If the patient still continues to, fails to comply, then she can be assisted in transferring to another hospital. For patients who aren't stabilized or in an emergency situation, a nurse or medical resident could be allowed to conduct the patient's initial evaluation, but it has to be made clear that the assigned physician is still in charge and that having someone else perform the evaluation is outside the standard of care. And finally, if other emergency physicians are available, it's reasonable for all the physicians involved to decide amongst themselves whether to accommodate within practical constraints, and if doing so doesn't jeopardize the treatment of other patients. So for example, with the patient in case study 2, this is in fact what the physicians did. They decided to accommodate the patient's request. He then accepted care, made a full recovery, and went home. Regardless of which approach one takes, patients have to be informed that racist or hateful speech won't be tolerated. Now, to be sure, accommodation is clearly not a perfect solution and obviously isn't a fully satisfying answer to the problem of race-based health disparities or physician bias. And none of this is to suggest that we shouldn't be concerned about bigotry or racism on the part of some patients, or cases where a patient isn't just requesting concordance, but is explicitly rejecting a provider based on his or her race or ethnicity, because this tends to disproportionately and negatively affect physicians of color, clinicians of color. And each time it happens, it's like another slice of the knife, and the cumulative effect can be significant. These experiences are painful and demeaning for the physician involved and can exact a heavy emotional and psychological toll, which contributes to burnout. I'm sure many of you have heard of the recent case of a pediatric resident a black pediatric resident who went into a room to greet her patient. She introduced herself to the parent of the child, and then she got down to give the child a high five, and as she was about to do so, the father turned to her and said, "Don't you touch my child." Even if the resident decides not to continue working with this family, the episode isn't over for her. The experience, the emotional and psychological weight of the experience will probably linger. So today we're in a very patient-centered culture of care, which is important, but we can't forget our first-line providers. So when these cases arise, there has to be an opportunity for the affected staff to talk about it, to debrief. There has to be a formalized process in place, and this is particularly important when these cases involve residents and trainees. A study from last year found that 19% of trainees experienced discriminatory verbal abuse. 93% of over 400 first-year residents had experienced disruptive behavior, including racial bias. 15% of these residents had personally experienced or witnessed mistreatment. And 50% didn't know how to respond to these encounters, while 25% believed that nothing would be done if they had alerted hospital leadership about the encounter. Now, this tells us something. This tells us that institutions may not be appropriately supporting their staff, particularly residents and trainees. So institutions really need to be there for this group. They need to know they'll be supported. They need to know that someone will have their back. And this can be done in several ways. First, through debriefing and follow-up. Sitting down with the resident, trainee, attending physician one-on-one, it's about taking people's difficult experiences seriously and giving the person a chance to vent, preferably to someone with debriefing skills or someone who's trusted and who's facilitation skills. And it's important not to minimize the encounter and to really commit to understanding how the staff member may have experienced it. In addition to debriefing with the rejected physician, the institution should also address the fact that these encounters can have a corrosive effect on other people who witness it, who may not know how to respond or what to do. So you may want to have a whole team discussion. Okay. Those on the team who've had these encounters can talk about what worked for them in terms of how they addressed it or what didn't work, right? And this is important because prevention is impossible. These types of members of the team will likely have this experience at some point in their careers, and if they don't have this experience directly, they'll likely witness it or see one of these encounters. And by these encounters, I don't just mean rejection based on race. They're rejections based on gender, rejections based on religion, based on disability status, based on age for that matter. I'm sure many of you have walked into the room and the patient has said, "You look too young to be a doctor. I want a more seasoned doctor. I want some gray hairs. I don't want you. You look like a kid." So the whole team needs to learn how to deal with these encounters. Another reason to have a whole team meeting is that some members of the team may not know that their colleagues are even having these experiences. They may have no idea. So you want to bring these incidents to light, not only to inform the whole team, but also as a means of protecting the person who's experienced the rejection, to keep them from internalizing it. Because these rejections can feel like an assault, and internalizing the experience is more likely to happen if the clinician feels alone in the experience or feels that they won't be supported, or that people will accuse them of being overly sensitive. Because for some providers, these experiences could be a microaggression that comes on the heels of many, a macroaggression that comes on the heels of many microaggressions, like constantly being mistaken for the television repair person, as opposed to the trainee, resident, or attending physician that you are simply because of your race or ethnicity. So you want to support the staff with an eye towards creating best practices. In addition to debriefing and having team discussions, you should track and collect data on these physician-patient encounters to get baseline information on how often they occur, the institution's response, the ultimate resolution, the effect on physicians and other providers, how affected personnel are supported, and how affected personnel feel about the encounter itself and the institutional response. Because again, these discussions tend to happen, if they happen at all, these discussions tend to happen in small silos. So there needs to be a meaningful, systematic understanding and response. So create a prevalence map. What departments is this happening in? Now, of course, this isn't as simple as tracking a MRSA infection, and this is a big commitment on the part of an institution. But the more information you have, the better your response will be. This debriefing, strategizing, tracking can be used to create best practices with the ultimate goal of supporting staff while improving the handling of these situations. Okay. So these 5 ethical guidelines that I've outlined are helpful when these cases arise, but we also need to come up with more long-term means of addressing these concerns. And by these concerns, I mean concerns about minority physicians in these encounters, as well as concerns about patients who may feel anxious about the possibility of experiencing physician bias. The medical profession as a whole has to go beyond accommodating patient racial preferences to expanding cultural awareness at all levels of practice and training so that providers can interact more effectively with various patient populations. We need to train a more culturally competent core of physicians. And finally, the profession has to increase diversity among providers, beginning in medical school. So for example, 80% of ER physicians today are white. This diversification needs to be done with an eye towards encouraging tolerance and understanding of other cultures. We need a more multicultural physician workforce that reflects the diversity of the patient population it treats, because this leads to more positive outcomes. It improves patient satisfaction, it strengthens cultural awareness, and it promotes sensitivity and tolerance among professionals. But it also may have the added benefit of reducing physician bias, along with the need to accommodate patient racial preferences in the first instance. However, until this happens, these 5 ethical guidelines, along with persuasion, negotiation, and if necessary, negotiation, constitute a clinically, legally, and ethically appropriate course of action. Now, to sum up, patients who demand accommodation for their racial preferences create a difficult conflict for healthcare providers. And this conflict involves their professional obligation to provide non-discriminatory care, their sense of social justice and personal integrity, and their ethical obligations to respect patients' autonomy and medical best interests. So when these physician-patient encounters arise, healthcare institutions should not force their providers to accommodate or not to accommodate, because forcing them to do so will violate employment laws. But it may be appropriate for individual clinicians to decide amongst themselves whether to accommodate. And their decision will be sound if the accommodating clinicians are comfortable with the decision and there are processes in place to provide institutional support and guidance to the healthcare professionals involved, and if their employment rights are protected, and if the decision doesn't compromise the provision of quality care. Thank you.
Yeah.
So I'm just curious, how many of you have been rejected by a patient, not just on race, but on a category, that on gender, religion, where they think you're from? Okay, so yeah, that sort of fits the data. And can I ask how you responded? Anybody want to? Sure.
Comply with the requirement.
Anyone else? And was it a difficult decision? Or you just didn't, you're done?
I think when I am the one asked to move from here, I comply and I don't, But if it's one of my residents or my team, I try to speak with the patient. Even I don't force the resident, but it's easier to be an advocate for another person.
Yeah.
And I think one of the things, for example, like for us, women many times, they call it miss, that's really upsetting. And
As opposed to doctor.
exactly. Anybody who's a white coat that is a male can pass by doctor more than a female, it seems. But recently I was reviewing the prescribing scores for my clinic, and I got a very good review about myself, but it was miss, and I sent it to my regional chief. I sent the scores of the physicians, and I was commenting like, okay, I was downgraded as miss. So I was told that for female physicians, I don't know if it's for everybody, but now there are tags for doctor for the female physicians. And I think that is still, either we all use it or nobody uses it. That's my perception.
Okay.
Are we still answering your question, or are we asking our own questions?
Does anybody else want to volunteer their experience before we move on to other questions? I think it's always interesting and helpful to find out how people respond. Okay.
So So I mean, I was going to answer the question, but I don't want to monopolize that. So for me, it was unusual because I'm Jewish and have a yarmulke and was observant, and the patient who was rejecting me was also Jewish, but an atheist, and really uncomfortable with the fact that his doctor had this other set of beliefs about God and religion, and pushed back on the fact that he really didn't want me to be his doctor. And ultimately, we were able to he didn't say that at first. He just said, "I don't want you to be my doctor."
Just like that.
Yeah, and so then over the course of some time, we talked about it, and he opened up and explained that was the reason, and I tried to reassure him that despite what was on my head, it wasn't going to affect the way that I treated him. I was going to do my best to make sure that was the case, that we separated those things, and he agreed to see how it went, and so I ended up caring for him, but it was quite unexpected. So the question I had is about the concept of concordance, and how worried you are that can easily slip into a scenario where a bigot who's either read your paper or seen your presentation could say, well, I'm not a bigot, I'm just looking for race concordance, I want a white doctor, and it feels like a slippery slope if we use it in some instances but not others, although I completely understand where it's coming from, and I know that it makes lots of patients more comfortable, more trusting, less vulnerable. So how do we...
That's a great question, and I think we can cabinet if we can link their concerns or their fears to something more tangible or concrete than I just don't like you people. And so the example would be the perhaps white veteran who is essentially saying, I don't like you people, but we can link it to something concrete, something that negotiation or persuasion is probably not going to work. And without the accommodation, it is going to affect the therapeutic relationship. It's hard. It's hard. We can't cabinet in all instances. But I think there are certain populations where they have we can find a legitimate concern that may not be addressed, may not be able to address based on.
Well, first of all, congratulations on taking on such a difficult and important subject. Secondly, most of us were educated to believe that all of this bias stuff is acquired, but I wonder if there would be some research about the possible hereditary genetic aspect of this, not to get people off the hook, but to give us a different point of view as to how widespread in so many cultures this racial bias is. I think it may be genetic.
Well, I haven't found any data to support a genetic link to racial bias. Of course, what is considered a race differs from culture to culture. The types of divisions that exist in certain societies aren't necessarily based on race. They might be based on caste. They could be based on socioeconomic status. They can be based on what subgroup you're a part of. So perhaps we could say part of the human condition might be intra-group conflict. But in terms of racial animus or racial, that's socially constructed, and there is a lot of data to support that. Yes.
Another potentially more subtle form of racism against clinicians could be in the form of patient surveys of satisfaction, which now is really prominent in what we do. It affects reimbursement, incentive. I wonder, do you know aware of any evidence of racism or implicit bias in evaluations by race or by gender?
In terms of how people fill out? No.
Yeah.
Do you want to say a little more about what you found? Or what your instinct is about whether or not it exists?
We have a large group of inpatient doctors here. We see a little bit of a trend towards lower scores on for younger females. Is one thing we've noticed sort of anecdotally.
Yeah.
Sort of looking at that a little bit in more depth to see if that's, an implicit bias or some other evidence of discrimination.
Well, again, data would seem to support that as implicit bias. Still, today, young women don't look like what many patients think a doctor should look like, and that may cloud the relationship. But that's interesting. I think that might be a really fruitful area of study if someone has already started that. Please.
Can you speak a little to how diversity in institutions institutional leadership may impact hospital policies and responses to this?
So, that's a great question, and that's really, it's important, and I think it does make a difference. So a lot of institutions tend to focus on policies and protocols, having, you know, the piece of paper in place that can tell us what to do. But culture and norms are a big part of you know, it signals to patients and to providers what's important to the institution. And so I think having diverse leadership, having norms of supporting people when they experience these encounters. Something as basic as I did this talk at a sort of a, you know, an Ivy League institution, and I walked in, and every picture on the wall was a white guy, like an old white guy. And I thought, like, what kind of messaging is this sending? But I didn't say anything. And then the residents were like, "Did you see the pictures on the wall?" You know, like they were picking up on it. And so all of that is really important. Also, perhaps, you know, just having people who look diverse isn't necessarily going to guarantee that you're going to have respect for diversity. But it is important for the frontline providers to feel like these issues are taken seriously, and not just, you know, we have a policy. Yeah. And also, I think it's not, just going to your point of, you know, other ways that we can support people. With regard to the norm and culture shift, also having policies is important, but also having a culture of making people feel safe reporting. So again, if you're going to report that this happened, that it's not going to be swept under the rug, that it's, you know, you'll say it and it's never, you have no idea what the resolution was, which is what was happening in, you know, all the Silicon Valley and with the tech industries and the gender discrimination. A lot of that is just, they need to work on the norms, and I think the same thing can happen in a medical context.
One more question.
So I want to follow up a little bit on what Dean Muller asked earlier. You gave your 5 case studies, and, you know, 4 of them, it's patients who are seeking to achieve some degree of concordance with their clinician. And it sounds like it's acceptable for us as individuals or the institution to strive to provide that concordance. But this sort of requires us to judge the patient's motivations and to decide that this is acceptable to us or this is not. We do this all the time in some respects with other types of requests for or about care. But when we go back to the bigot in case 1, I don't think he's going to be that, or let me recharacterize this. I don't think that he's going to be free of an increased level of discomfort with his care situation, with a non-concordant physician. You know, even though it's just coming from bigotry, I think that the patient in case 1, and I think most would agree, would be much happier with the white American physician that he prefers as opposed to, let's say, me. But, do we owe him less in terms of just his experience as a patient, in terms of his comfort because he is a bigot? And if so, does this translate into other areas of his care as well?
So are you asking, by not accommodating, if the physicians involved decide that they do not want to accommodate his request, are they giving him a lower level of care? Is that what you're asking? Than they would a patient?
That's close enough. I've been up for 23 hours. I'll go with your characterization.
I want to make sure I have what you say. It was, you know, long question. So, okay. The patient will be given options. I mean, I think the best practices would be to give the patient options and really test how committed they are to this belief. In my experience, anecdotal, talking to physicians, the bigoted patient, when told that they're going to have to leave, will often take the provider. They're not going to like it, but they'll take the provider given until they can find the provider, you know, find the provider they want. They don't just reject the physician. The patients who are like, I really just can't be treated by you, tend to look more like case study 2, the elderly Korean gentleman. But again, bright line rules are hard in these scenarios, and I don't advise them. I mean, I really think it's patient by patient, it's staff by staff, it's circumstantial. You might not be able to accommodate. Everybody on staff might be of color, like you just might be out of luck. But with regard to him getting a lower level of care, let me throw that out. What do people think? Yes, Ed.
I think that in the comment in the back, there were heard two aspects. One is, why should we impose our values on him? And the other was, would be causing him distress and a worse outcome if we forced him to accept what he didn't want. So I see them as two different questions. The first one is kind of relative ethics. If you believe that being against racism is simply your choice, I don't agree with that. I mean, we have to believe there are better ways to do things than that. As far as injuring him, I think it does depend on the urgency of the situation. If he's in crisis and about close to death and he says, I want a white doctor, if you've got one, you probably don't want to increase his anxiety.
I think that's right. Anyone else want to weigh in?
So I hope this space gives us an opportunity for all of us to personally reflect on this issue and to continue this conversation as we walk through the hospital and take care of our patients. So I want to really thank our speaker for engaging us.